I think advanced care planning is actually a process to connect not only between the patients and the family, patients with us as healthcare professionals, but also patients with themselves to know better about themselves after the process of reflection about their disease and what would be important for them in that situation.
That was Dr. Diah Martina, an internal medicine doctor from Indonesia who also has her PhD focusing on culturally sensitive advanced care planning. In this episode, we talk about what culturally sensitive palliative care looks like in Indonesia, what her research has shown about adapting conversations to different cultures and religions, and the relevance of the waiting room revolution for Indonesia and Asian communities. Hi, I'm Xian Xiao.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Diah, welcome to the podcast.
Thank you for having me.
We're so excited to have you.
I know you're joining us from Jakarta, Indonesia. So thrilled to have our international guest. And I know it's nighttime there, so thanks for making time for us.
Yeah, thank you.
I'd love to hear more, a little bit about your story and your career path, and how you've gotten to where you are today. I say that very generally because I know you're an internal medicine specialist, but you're also getting a PhD in palliative care. And so I'm just curious about the journey of how those things happen.
Yeah, so thank you for the question, Shan. So actually it was started in 2016. So it was my last year as a resident. And at that time, I was doing my night shift in a hospital. And at 2 a.m., there is a patient newly admitted to the ward. And it was reported that the patient has a very low oxygen saturation, very low blood pressure. And then when I came to the patient, so I saw the patient was unconscious, and then the X-ray showed massive metastasis, unknown origin. And the family has not had a conversation with the patient before. So that was when I started to communicate with the family about the very low chance of success if we do resuscitation to this patient. But despite all of the efforts, the family asked for maximum, whatever I can do to make the patient survive. So when the heart stopped beats, actually, we started resuscitation. And that time, during the resuscitation, I felt there is a cracking under my hand. So the chest broke. And at that time, I felt like it was my heart that broke. I always thought I have tried my best to become a good doctor for my patient until that day. And at that time, I realized I want to study palliative care. I want to do research about how to do this kind of conversation in our context, our culture. And that was when I decided I want to research advanced care planning abroad. So in 2016, I went to the Netherlands. I took a fellowship in palliative care. It was a grant from European Society of Medical Oncology together with my family. And then in 2017, so it was a short observation fellowship, followed by I took a grant from American Society of Clinical Oncology. It's an International Development of Education Award for palliative care. So I went to Boston, Dana-Farber Cancer Institute, and met my mentor there. I observed how palliative care is delivered there. And then I went back to the Netherlands and do my PhD on advanced care planning. I have just finished my PhD last year, July.
Congrats. Congratulations.
Thank you so much.
Wow, what a trailblazer you are. Um, they're so lucky to have you.
Thank you, Sammy. I'm
Yeah.
lucky to be there too.
Oh, yeah. And how this was born out of your heartfelt experience, having to resuscitate someone when you didn't feel it was appropriate. Yeah. I have a question about the role of the family in Indonesia in terms of, what's their role when someone they love is dying? And how often does that happen at home versus in an institution?
Yeah, thank you, Sammy. So maybe you've heard or you're familiar with this among Asian populations.
Mhm.
Family has a very important role in Indonesia. They do most of the care. And the home care service in Indonesia, we don't have yet, for instance, hospice for palliative care.
Mhm.
Home care is not supported by the insurance. If it's delivered by the hospital staffs. Yeah, sorry, can you remind me again with your question?
Yeah, the role of the family.
Yeah, so most of the decision making is made by the family, and it's
Mhm.
rather normal for healthcare professionals to actually discuss diagnosis, prognosis, and make a decision with the family first. And then they will decide, usually the family will decide whether the patient will be involved in the discussion or not.
Mm.
And how does that
Mm.
work? Because obviously that's very different, maybe even the opposite of what it is in, say, North America, where it's, patient autonomy and privacy is paramount, and sometimes the family aren't involved. So is there often the situation where the family does not want to reveal the diagnosis to the patient, and the patient is really sort of in the dark?
That is very common, actually, Sian, and that's why I think why I did my study is because how do we actually tackle this kind of dilemma? You want to, that the patient needs the information, but then you do not, and I think not only in Indonesia, but also in other Asian countries, many of healthcare professionals do not want to have a conflict with a family. They try to maintain a social harmony. That's a very important value in Asia and in Indonesia. So I think part of the studies, the findings of our studies is that we know that healthcare professionals think families are very important, and they would always involve family in all of the discussion and decision making. But we also know that according to the patients, they want to involve family too in their discussions. And when they do not do not want to think to engage family, it's because they want to protect the family, just the way the family used to want to protect the patients. So I think what our study recommendation is, basically it's really important to address families' concern, and that is as important as addressing patients' concern. That's how you want to put them in the same table to make a discussion between both of them to hopefully elicit shared understanding about the important values among both of them.
So what happens in a situation where the family doesn't want their loved one to know, but the patient might be asking, why am I getting weaker? Why am I not eating as much? What's going on with me? In your culture, how do you reconcile that conflict?
Yeah, it has always been a very difficult situation there. And usually in this kind of situation, if there is palliative care specialists and it is palliative patients, they would consult us. And actually, for us, it's also not a really easy case. But what I have learned from clinical experience, but also from the published studies, is actually understanding the family sides is really important, and trying to find how to align, how to create an alignment with them. So what is important for them, what concern them, and we want to say that that is also important for us too, and we agree with you that it's important. So, so work with the family. Yeah.
Even though it's not the cultural norm here, we have the same experience often. Yeah, so we try to do the same thing. I love your term that you use, social harmony. Did you make that up?
Oh, no.
I love that term.
Well, we did systematic reviews among Asian studies published in journals, medical journals. So from our systematic reviews, we understand that these are among the important values in Asia. We also found that too in Indonesia. Yeah.
I mean, we've been talking about the family, Diah, but your research also talks about culture, religion, spirituality, faith, and language. So I'm curious about how those factors play into this idea of palliative care, what your research found, and how that's, adding to the nuance of what people think of how to do this well.
Yeah. So basically, my study really focused about culturally sensitive advanced care planning. So how do we do or engage patients in advanced care planning, but really considering about their culture. And this also involves religion, beliefs, and language. So what we have learned from our study is that it is really important to understand patients' preferences for information, how much they want to know, what kind of information they want to know, but also how they want to be engaged in that conversation. Sometimes some patients in Indonesia want or prefer implicit communication, and they have certain preferences for information. For instance, certain information may not be relevant for certain patients because of their religious beliefs. When you talk about prognosis, quantitative survival for many Indonesian patients who are religious, and Indonesia is one of the most religious countries in the world, this might not be relevant because among the believers, they believe that it's not in your hand as a physician, it's in God's hand. So approaching advanced care planning and discussing about the future might not necessarily discussing about prognosis or survival, but maybe we can talk about what is important for them. So meaningful conversation about what a good life means for them. And maybe eventually when you already have that kind of doctor-patient's relationships and trust, you can talk about what is a good death for them. And about religiosity, it's interesting that in our study in Indonesia, but not only my study, just a couple of weeks ago, new published study from Indonesia also actually finds similar findings about the importance of framing or creating an alignment between what you want to deliver or convey, for instance, advanced care planning. Then you want to find what is the important values in their beliefs that may be in alignment with advanced care planning. For instance, in my study, we found that when you talk about the futility of treatment, and then you use the term, use statistic, it's just difficult for them because even 1% of chance might be worth it for them who believe that life is something that is sacred from God. But when we approach it from their point of view, saying about the harm. So in Indonesia, there is a term called mudarat, and that is an Arabic word. It's actually the same meaning with harm. But when you say that we are concerned about the mudarat will be more than the benefits, they would really understand and grasp the idea of utility rather than talking about the statistics. And many of the papers really talking about among believers, the engagement of advanced care planning is low because of the fatalism, that they believe that God decides everything and they should not maybe plan about the future, well, or do anything about that. Well, it's an interesting study just recently published, also trying to create alignment with, well, in Indonesia, it's Islamic then beliefs about tie your camel first and then rely on God. And that's the prophetic statement about you need to make an effort first, but then you can then rely on God. So that is explaining that you are not giving up, but we already tried. And then after you tried, then we really believe in God's will after that.
So Dia, I love Proverbs, especially Chinese Proverbs, but I'm not sure I fully understand the one you just said. So I'm going to repeat what I think I heard. You said, tie your camel first and then rely on God. What did you mean exactly?
Oh, let me try to explain what I understood. Okay.
Yeah.
I understand that proverb to be, at some point, if a person starts feeling like they've given up, then someone could say this proverb to them and they would be reminded that they're not giving up, that they've tried multiple things already, and that relying on God is not giving up, that it's
an action,
it's acceptable.
Correct.
Is that right, Dia?
Yes, yes, correct. Also, this actually, this saying originates from Arabic person at that time who actually did not tie his camel, and then he lost the camel, and then the prophet asked, why did not you should tie the camel first and then rely on God. Do not just rely on God. So it's actually illustrating the importance of balanced approach between the effort, practical measures, but also keep on maintaining faith in God's.
Oh, it's almost like what the name of our book, Hope for the Best and Plan for the Rest.
Correct. And I always actually say that to my patients. I think that's a very, very great approach. So I love you.
Yeah, it's similar. You know what? You're giving us such amazing tips for when we have patients and families from Indonesia. Like, I'm already learning that talking about prognosis is probably not something, they're particularly interested in, although individually they might be, but culturally it's not really something that they're interested in, and statistics are not really high value, but their underlying values are important to help guide discussions and how important the family is in decision making. So it is really important for us to understand these nuances between cultures, so that we can meet them where they're at, and have social harmony between the medical system and the family and the patient, right?
Yes, thank you. Yeah.
Hey listeners, you're halfway through the episode. We want to remind you that our book, Hope for the Best, Plan for the Rest, is available everywhere you buy books, in softcover, audiobook, and ebook. And did you know you can leave a review on Amazon without purchasing directly from Amazon? All you need is an account. And reviews help others find our book when they need it the most. So thanks for your support, and there's lots more to this great episode, so keep listening. Okay, so we just brought up the book. So Hope for the Best, Plan for the Rest, which you've read. And we get this question all the time. I'd love to know what you think about it and whether you think it's relevant for the Indonesian or Asian culture. Because I get that question and I don't know how to answer that.
Yeah. So I think that has been really helpful. I always approach my patients like that. So I always say to them, maybe a little bit differently. So I also hope for the best. So sometimes I say, I pray for a miracle together with you. At the same time, I need to prepare, or we need to prepare for something that we do not want to happen.
Mm-hmm.
Yeah.
Yeah.
So when they say miracle, I usually explore what they mean by miracles, and then I also put myself in their shoes and then say, I also hope for the same. I will pray the same with you. Same miracles. I also hope for the miracles. At the same times, I would like to have us prepare about the worst case scenario, for instance.
Yeah, I do that also, Diah. When people are extremely faithful and religious and they say, you know, we are hoping for a miracle or we're praying, and that's how we're going to focus. I say the same thing. Well, I am also hoping that you get that miracle. Wouldn't that be amazing? But just in case, can we plan for what if? What if things don't work out the way you're praying?
Yeah.
Yeah.
Yeah. Sometimes I also use the metaphor of insurance. So we buy insurance, not hoping accident to happen. But
Yeah.
then you get like the feeling of comfort, feeling safer, feeling more comfortable. And then if anything happens, we know that we already have insurance.
You know what? I'm appreciating so much that we who work in palliative care have such incredible ability with our communication, our language, our words, our metaphors. Like I've written a few things down, the comfort that you get from insurance, but you're not expecting. But it is true that this is our secret weapon. It's not so secret, and it's not a weapon, but this is like they compare it to the scalpel and the surgeon, where our tool is our language and our voice. And it does take some practice, but really, in theory, we should be able to teach this to all healthcare learners, right?
Agree, yes.
So
I love your language.
yes. And besides the title, and I'm not putting you on the spot because I mean I don't know how much how much you've read. I know you're very busy with all the fellowships, the international fellowships and awards you've been winning. But I mean, are some of the keys, are there any keys that jump out to you that are relevant? Because like this idea of zooming out and and talking about the big picture of the illness or knowing your style, are those things that are relevant? Are they culturally appropriate? Can they be adapted to different cultures?
Yeah.
Or yeah.
Yes, I think your book is actually quite universal. That approach is appropriate for our culture as well. I think in general, the communication skills maps may not always be relevant for our culture, how I see it, right? Not everything is translatable. That's not how we communicate it in daily language in our patients. But I think your book talking about hoping for the best, prepare for the rest, this is really relevant for, I think really universal. In Indonesia, it's really acceptable. And I do that quite daily, even before I read your book. So when I read your book, I really like someone write this, yes.
Yeah, because of course, working in palliative care, you already use all of these skills. But the thing that we were trying to do is bring these ideas right to patients and families and offer these skills without labeling it palliative early in their journey so that they could learn how to be a patient and how to be a caregiver and get what they need without feeling so in the dark.
Yeah.
Okay, Diah, I really want to ask you this question because I've been thinking about it a lot. See, on the one hand, there seems to be communication skills that are universal and could be applied to any person, maybe like principles. And yet, on the other hand, there seems to be skills that need to be adapted to different cultures. So, are these in tension? I mean, or how do you view these two concepts that seem to be opposite, but also seem to both be true?
Yeah, so thank you, Xian. That's a really brilliant question. Actually, I am drafting a grant to work on that, really to learn in Indonesia, working on all of these communication skills and how to adapt that in Indonesia. And then we will know how much of that is actually working and how much of that needs to be adapted. But for instance, how I understand it, some of them need to be conceptualized. For instance, planning in advanced care planning. Planning might not always be relevant for Indonesia. Or for instance, we did systematic review in among Chinese immigrants, and advanced care planning definitely is not a familiar concept for them. But then when we try to put it into context of, pre-arrange something is really in ancient China, only emperors can do that. So do you want to be an emperor or do you want to be a peasant? Something like that. So also only emperors can actually decide it, where they want to die, their grave, what do they want to wear, for instance, that day. So putting into the context to make that familiar, because in our study in Indonesia, every time I do this qualitative study, they would say, that is really Western idea. That's not how we do it here in Indonesia. The idea of planning in advance is complex. So what I think is general is actually exploring values, exploring beliefs, exploring preferences and wishes. Knowing who you are as a person. I think advanced care planning is actually a process to connect not only between the patients and the family, patients with us as healthcare professionals, but also patients with themselves, to know better about themselves after the process of reflection about their disease and what would be important for them in that situation. I think when we talk about advanced care planning, that the planning itself can be quite complicated in Indonesia. It might not necessarily be called advanced care planning, I would say. If you want to tell culturally sensitive approach, it might not necessarily be called advanced
Yeah.
care
What would you
planning.
call it? Because that is such a big problem, right? Just like palliative care has a branding issue, advanced care planning also has a framing and branding issue. So do you even give it a label, or do you just
Not yet.
do
We're
it?
not that far yet. But it
Well,
will.
maybe you want to call it, would you like to be an emperor or a peasant?
Yeah, that would be great.
Yeah.
What do most people die from? What's the number one cause in Indonesia?
Yeah, cardiovascular disease.
Yeah, same here. Yeah.
Mm.
And what is the most common cancer in Indonesia?
Or it will be breast cancer.
Okay.
Yeah. And nasopharyngeal cancer.
Right. Yeah. Here it's lung cancer. Yeah.
It's the third for us, I think.
Yeah. And how about like how about dementia? Because that's a big one. And what does that look like in Indonesia? Because that, when it has a long tail, that's when we really need community supports and caregiver support and things like that. What does that look like in Indonesia? Like the
Yeah.
community around the patient and their family. Yeah.
Yeah. So we don't have yet a nursing home for geriatric patients here. And it's really not, maybe not part of the culture, because as the children, you're expected to take care of your your parents. Yes. The
Mhm.
filial piety you might have heard. So that is really the obligation of the children to pay back to the parents and take care of them. And but we have now emerging specialists in geriatric in Indonesia, and geriatric center are now evolving in several parts of Indonesia. So I hope in the long run there will be more studies and also comprehensive care for elderly. And well, for dementia we have around, I think, 1 million per statistic in Indonesia. Yeah.
Mhm.
And where did you say most people die?
Where?
Yeah. At home, in the hospital, in a
In the
hospice?
No, we don't have hospice in Indonesia
Okay.
yet.
So in the hospital, most people die in the hospital.
Most patients, most people die in the hospital unless it is in a very rural area where
Okay.
access to hospital will take hours.
So people stay at home with their family caring for them as long as possible, but most people end up in the hospital at some point and die in the hospital.
Correct. So when they think the patient is dying, most of the time people will bring them to the hospital.
It's so interesting because, as you and I both know, I think the most difficult part of caring for someone is before they're actively dying. You know, in the couple of months before, when a person is really declining and they're needing more personal care, you know, in the last couple of days, hopefully the person is comfortable and the family can just grieve, you know. But so it's an interesting time to ship someone to the hospital to die. I'm wondering if maybe there is a cultural concern about someone dying in the house and then you still have to live in the house. Like maybe their spirit won't leave, or is there anything like that?
No, there's nothing like that, but I'm quite familiar with that, but I don't think it's in Indonesia.
Okay. So
It
it's just that
depends.
there isn't enough knowledge and understanding from the family how to care for someone at home while they're dying.
And there might be not enough supports, and
Yeah.
so they don't know how to do that, but they also do not have anyone to tell them what to do. And
Yeah.
home care service that is free available that they can access. So either they are very rich to be able to afford nurses to help at home. Otherwise, that will be very complicated for them to take care of people at home.
Yeah, because here I would say that the number one barrier to people caring at home, being cared for at home and dying at home is mostly because children do not usually live with their families here. And so we have many people living alone, dying at home, and you cannot really do that on your own. And so you in Indonesia are rich with family connections and family who actually physically live under the same roof. And here we have a certain amount of home care, but the family layer is often very thin. And so it's interesting that that's a difference between us.
Yeah, Sammy, I think it's because not everybody would know that it is dying process that they can see first. So most of them would think that there might be something that can be done.
Yes, yeah, exactly, because they don't know what normal
Correct.
dying looks like. No one's told them what to expect. So if someone stops eating, that's an emergency. Or someone's sleeping more, that's an emergency. Or they can't get out of bed, that's an emergency.
Correct. And since you talk about eating in Asia, but especially in Indonesia, actually always ask to your children whether they have eaten or not, but actually it's like an expression of love,
Yes.
right? So
Yeah.
yeah, so it's really symbolical. So
Yeah.
really important in Indonesia
Mhm.
culturally to provide food.
Yeah. And so if a person's not eating, which is very normal, at the end, slows down, the family feels like they are not doing a good enough job, or,
Correct.
They're
there's
not, it's
something
love.
we,
It's a physical
yeah,
symbol of love, not just in Indonesia, in many cultures.
yeah,
Ah,
yeah,
Italian, Jewish culture. I mean, many cultures use food as
yeah,
as a physical representation of love.
correct.
yeah. There's
Can
so
I just ask?
much we need.
Yeah.
Yeah.
No, no, finish
Was
it.
saying there's so much we need to do, and there's lots of people trying to um to talk about normal dying and what that looks like and what to expect. I always tell people how, our body knows how to go through this very normal stage of life, no matter what the trigger is, whether it's heart disease or cancer. It triggers a similar process of just slowing down
Yeah.
with these very normal features we see. But I can appreciate that if you haven't been told that, every change is um, your responsibility to make sure that it's not reversible,
Yes.
Yeah,
as a family.
yeah.
Yes.
Can I ask, because we talked about where people typically die, and you said hospital, and I'm assuming their last few days or weeks. Is that when they first meet you, Dia, or have they met you like earlier on in their illness?
Yes. So most of the time I am consulted for dying patients, correct?
Mm.
Hmm. Yeah.
Yes. So that's your story is similar to ours, where you meet people so late and you're putting them back together at the
Yeah.
end. And sometimes you might feel like they've had a really rough time, and people might say, I wish I had known that sooner. And so that's really where some of our hope is, that it can't be you and Sammy at the end trying to fix. You're not going to be positioned early. They're not going to refer to you early, or there's not really the same kind of role. You're so busy at the end. But if we can teach patients and families how to ask questions or get information that will be helpful for them if they want earlier, then even having not met you, they will still have a better picture of what to hope for and prepare for. And maybe hopefully they'll at least know how to weigh the benefits of CPR, say, so they're not, in those few seconds having to decide.
Yes.
Yeah, that's our revolution. Anyway.
Yeah.
I'm wondering, Dia, if in Indonesia there is a big power gap between the doctor, let's say, and the patient and the family. Like the doctors are seen as, on a pedestal, and you just do what the doctor says. Um, and therefore you just don't ask a lot of questions because you have complete trust in the doctor that the doctor will do what's needed.
Correct. Yes. So medical paternalism in Indonesia is very common. It's not
Mhm.
only from the healthcare professional sides, but also from patients and family sides.
Mhm.
Healthcare professional sides, they think that these patients and family paid to come to me for my advice.
Oh,
So I need to give them advice.
oh,
And the patients and the family, that's like what you say, they are the expert. The doctors are the experts. So um, empowering them to be part of the decision maker, telling
mhm.
them that everybody are the experts. We as a physicians are the experts in the disease, but you are the expert about you. You know your family
Yes.
best. You know what's important for you. You know your situation. The family is also the expert on their sides. So I think that's very important to empower the patients and family. Eventually, I think education also matter.
Mhm.
So in Indonesia, there are quite many parts where patients are really low educated. So maybe they not even finish elementary school. So in that sense, most of the time, that kind of patients will be really giving all the decision to the physician. Engaging them in the decision making can be quite challenging because they know nothing and they think that they cannot understand. And I think when we talk about literacy, that's not the patient side. Patients might feel challenged to understand what we say because we often use medical terms, but I think medical literacy is also in our side. Maybe we are not able to talk in their language, simple ways, so that we can encourage them to be involved in their own decision making.
Yeah, you know, because I work in people's homes, do you go to people's homes as well?
So I has been a hospitalist all this time, but now returning to Indonesia after learning about palliative care, I was expected to set up palliative home care service in 2 hospitals. So I tried to learn about that. I went to Malaysia, to Hospice Malaysia, to observe how they deliver a home care service. So I would say I already know about that, Sammy, but I am learning to do that.
Yeah. Well, you're welcome to come here. You can stay with me and you can drive around with me. But I was going to mention to you that it's very rare for people to be exposed to home-based care here in North America, but for sure in Canada. Most of our training is in the hospital or in clinics, and it might just be just by chance that someone like a doctor does a home visit and learns in their training, you know, that is a very different care setting. But I feel so lucky that I have really worked most of my life in people's homes, and I have necessarily learned how to speak very plainly and with very common language, mostly because that's my nature anyway. I'm not very fancy in the way that I speak, but definitely appreciating that the families are my team. I'm joining them in their world. That the language, in order for us to do this together, we need to be able to understand each other, and they come in all different varieties of health literacy and education and competence to be able to absorb information. So I think that citizens would be better off if doctors did some training in people's homes and learned how to speak to real people, not just their colleagues.
Thank you, Sammy. Thank you.
Yeah.
I completely agree with that.
Yeah. So
I did have a question, and then we're almost nearing the end. But I mean, you have been all over, Diah, right? You have been into the Netherlands and the U.S. and in many different parts of Asia. What have you learned, and what is similar and different about providing palliative care in all these different countries?
can I just make one comment? Everyone says the Netherlands have it perfectly. So like over here, we think that, you know, they do everything perfectly when it comes to healthcare. So maybe, yeah, you can comment on that too, but.
Yeah, so I think each country is different. And it's hard to say which one is best. I think it really depends on the people, the norms, the culture, the values. For instance, when I was in the Netherlands, the first day I was asked, what do you want to learn here? And then I say, I want to see how you do euthanasia, because this is the country where I can see euthanasia. And that is not something I will see in Indonesia. Might never, I don't know. But yeah. And then after I observed how they do euthanasia engage with them, I understand why they do that. Might not be doing that, and that's but then I understand from their point of view. So how palliative care is different between countries, well, that's a difficult question. I think
Maybe a better question is, what did you learn from all of them? Because you're right, they're all different. But what have you learned from viewing all these different things that you're taking with you in Indonesia? Maybe that's a better question.
Yes. So what have I learned is that palliative care is the care that is humane, that you see a person not as a disease. You do not reduce a person into a diagnosis or into a tumor marker. You see them wholly as a person, and everybody deserves that. So I think that is a human right. The way we approach palliative care might be tailored in different countries. I think in Indonesia, you want to find what is the most deeply held values, important values in this culture, in these countries, and you find what is that in palliative care that you can find is in alignment with that values, and then you try to match that. And I think what I learned is you really need to know who is the ecosystem in your country, because it can be different in each country. I mean, you have nurse practitioners there, we have trained chaplains there. We don't have that here, but we do have many social capitals here. We do have a very strong family relationship here, a very strong bonding in the community. So I think compassionate community will definitely work in Indonesia. And I will say it's something that is newly discovered. I think in Indonesia, people have been very compassionate. You just need to organize that. So I think what I learned is to make palliative care work in Indonesia, you really need to work with you really need to contextualize with the culture. You really need to work with the champions in each different regions, because Indonesia is decentralized. And I think the most important thing is to work in advocacy, make it integrated in the policy and the national program to work here.
We're almost at the end of time. I'd love to, I mean, you can either answer the question of what gives you hope for the future, or what are you most excited about in the future?
What I'm most excited about in the future, yes. So meeting people like you, many helping hands out there who actually have so much expertise in the field. And we are the country that is still very young in palliative care. And knowing that so many experts are actually very, very kind and very, very helpful, and are willing to help in any way they can, has been a source of hope for me. So I feel like I have so many people that I can reach out to help develop palliative care in Indonesia. Yeah. I
feel like I have my first friend who's still living in Indonesia.
Oh, thank you.
It's so good to meet you.
It's so nice to meet you.
Thank you so much, Diah, for joining us today. Hey, thanks for listening. Don't forget to rate, review, and subscribe if you haven't already. Visit our website, waitingroomrevolution.com, for more information, to join our newsletter, and to check out our book, Hope for the Best, Plan for the Rest. This podcast is produced by myself, Kayla McMillan, Shilpa Jyoti Kumar, and Maggie Seebeck. And our theme music is Maypole by Ketsa.